I'm going to ask for questions now or pertinent comments. Throw it open to the floor. Anybody have anything to say? This is an intelligent-looking group of people. Yes.
Clinical trials, were they all on the same drug, and were those particular drugs all trying to treat the same symptoms?
Mine was the creatine, and I also did an interesting clinical trial that was through UCSF, which was an exercise type of trial. That was a 12-week program. So from the way that I understand it, each clinical trial is totally different from the next one, and the benefits for different symptoms. The creatine for me was neuroprotective to see if it would slow down. And my experience is very similar to yours with the Azilect. I forgot to mention I'm on Azilect also, and I'm lucky that my Parkinson seems to be slow moving too, and I'd like to think that the Azilect plays a big role in that, and I've done real well on that particular drug.
You know, it'd be interesting if you're interested in clinical trials to talk with some of the people here, because there's 26 going on right now at the Institute. Everyone is different. Some are on medication, some are physical, you know, how strong are you and how is your movement for it. I mean, you really have to sit down one by one and see what is right for you. And it's hard to generalize, I think. Typically, all the drugs are covered, so it doesn't cost you anything. There's payment for your transportation to come into the clinic back and forth. And you know, you get absolutely super care because the docs are looking at you every week or every few weeks on the results of the trial. So they're very worthwhile, and it's important that we have enough people doing the trials so that we can push the disease forward and find out what works and what doesn't work.
I hear you say that the medication you can feel on or off, and I don't know the difference because I don't feel on or off because I don't know what it's supposed to feel.
I didn't learn on or off for years after I started taking the medication. My body wasn't sensitive enough to the impact of the medication to hit me with an on signal or an off signal. But as the years passed, I definitely can tell when I'm on, when I'm not on. And for me, it feels like when I go off, my head feels like it gets thick, kind of cloudy. I feel slower. I feel a little more scared, actually, because I'm not afraid I won't be able to move. But my guess is it's something that you don't really understand until you've had the disease for a while and you're actually becoming sensitive enough to the medication to tell.
I have just been able to define it or notice it, and I'm 5 years in. So in the beginning, I didn't really understand that term either. And I even thought maybe something's wrong with me, or maybe I don't have it. You know, I was always quick to jump to that, and I'd call Dr. Brandenburg, all right, let's go over this one more time. Do I really have this? She's like, yes, you do. For me now, when I'm off, I'm not a big tremor. It's more of an internal rattle that I feel, and I'm struggling more with some cognitive issues right now. So when I'm off, if it's something that requires steps, even emptying the dishwasher, it's because there's so many little areas that each item has to go to. I get very overwhelmed. Or cooking dinner. If I just serve soup and I poured it out of a can, that works. But if I have to make a salad and dice it up and then do the garlic bread, when there's a lot of steps required to something, I get a little bit of panicky and a little fear-based, and with driving I'm a little tentative, and I notice when I'm off I don't have a clear understanding of the distance between things, so sometimes I feel like cars are going to hit me, so I tend not to drive on the freeway as much. And so for me it's a little bit more of a mind thing that I'm feeling when I'm off, not necessarily so much physical.
I think the big difference you find is with levodopa. At least that's in my case. The Requip, when I started with Requip and was only taking Requip, it didn't matter too much because the effect of the medication was not that significant. I mean, at the time it really helped, but my symptoms weren't that bad. And with the levodopa, when you're on that, for me, it's like a light switch. I mean, it's not on, all of a sudden, I'm great. You know, I feel like I don't have the disease, basically. So it's very, and I don't think it's necessarily true in all cases, but it's the levodopa that makes the big difference.
Okay, so medically on, off, on is the medicine's working, off it's not.
My pharmacist says, make sure you eat that with food. You take it with food. 3 times a day. So I'm a little confused.
He said that you should take it with food?
My pharmacist says that, let's see, what I'm on carbidopa, levodopa,
Okay.
combined in one pill. And my pharmacist says that I should take it with food.
I mean, I find that surprising.
So,
Well, we'll have the docs come and solve the question.
yeah, Dr. Tetra will come and talk about some of that, but I will just let you know, carbidopa and levodopa are always together. So you'll get those medicines every time you're taking levodopa, you're taking carbidopa, they go together. And as far as how it will make you feel, whether you should have food or not, some people do have stomach upset. So you might start with a little bit of food, but if you find that the medication is not working as well as it could, sometimes the food is actually hindering it. So it depends on the patient. Again, just like everything you're going to hear from every doctor is everybody's Parkinson's is different.
What kind of food are you talking about?
So the one that will usually affect the type of meals that would usually cause problems with the medicine is high protein. But that doesn't necessarily, it's not always the same for every patient. Sometimes for some people it's any type of food if they eat it right at the same time. It's a trial and error, unfortunately, for some people.
Yes, sir. Back row.
Hi. I was recently diagnosed and put right on a generic Cinemet. Then 6 weeks later, I went back to the neurologist just on Friday, and she said that she put me on that because she wanted me to have some symptom relief, but that it worked, but that it would stop working. What does she mean? Because what she did was switch me to something that made me very ill.
You know, that's a good question.
What does it mean
for
that
the
it
docs.
stops working, that it is ineffective, or that there's increased side effects, or what? She didn't explain.
Well, there was, one thing that I was going to say earlier that is usually a critical issue for people is when do you start the levodopa? Levodopa is the real true. This is totally from my point of view, okay? So, and I'm not a doctor, so take it with a grain of salt. But levodopa for me is significant. It solves my problem. When I take it and it's working, it's almost as if I don't have the disease. So it is the Class A #1 solution for Parkinson's. The problem with levodopa is after a period of time, there can be a reaction to it such that you have dyskinesia. And sometimes the dyskinesia is worse than the Parkinson's symptoms. So the general approach is to start on a minimum dose of an agonist or something else until you're uncomfortable enough that you really need the relief of the Cinemet or the levodopa. And so they push that out as far as possible so that, typically the dyskinesia can show up in some percentage of people. It's not 100%, it's maybe 50, 60%, and I'm thin ice maybe with that statistic, but only some people get dyskinesia. Some people get it maybe in 5 years, some people may get it in 10 years. It's a variable. So the question becomes, when do you start levodopa? From my point of view, I think about things going on in the pharmaceutical industry. There's a number of drugs, for example, that are attacking the dyskinesia issues, which is the result of levodopa long term. And I hope that they find a solution. And if they find a solution later on, I can't get back the days that I miss now if I'm not on levodopa. So my decision was 5 years ago to start the levodopa because my gait was hindered. I mean, it was hard to walk. When the doctor looked at me, he said, "Tom, you should consider starting levodopa." And I said, "Yeah, let's do it." because I wanted the comfort that it provided. Some people say, you know, I'm afraid to start it because I don't want to get the dyskinesia that's going to be on a short window, and that's a decision everybody makes that you need to talk through with your doctor. You know, from my point of view, I want to be comfortable today. I want to be comfortable today, and hopefully they'll find some solution in the future. And if they don't, okay, then I'll live with that.
I just wanted to, I'm not supposed to speak till later, but I just wanted to add to that. That was a very good description by Tom Follett of the issues surrounding the starting of levodopa. I happen to know that the only reason he really started is because he was concerned about his golf game, however.
I was losing so much money on that.
He was losing money, see, that's why he really, it wasn't about walking, it was about golfing. But for most patients, the decision to start levodopa is very individual and one that you make with your doctor. But I do want to clear up this idea that levodopa just quits working, because that's not true. Levodopa is a very good drug that takes care of a lot of Parkinson's symptoms in most people with Parkinson's. It doesn't take care of everything. And since the disease continues to progress and some symptoms develop that are not part of the dopamine system, there are some symptoms that levodopa will not treat. So when those symptoms develop, whether they might be cognitive or severe balance problems, levodopa most likely will not help with those symptoms. So some people say, well, see, look, the levodopa quit working. And you say, well, didn't you used to have tremor? Oh, yeah, but I don't have that anymore. Or didn't you used to have trouble with your handwriting? Yeah, but my handwriting is really okay now. Well, that's because the levodopa is still treating those symptoms. And people tend to sort of forget the symptoms they had before they started taking levodopa. So it's really not true that levodopa stops working. The real reason we delay using it in most patients, not every patient, is because of what Tom was talking about, that a certain number of patients, one study suggested about 10% of patients per year will develop some involuntary movements. The involuntary movements, almost every patient I talk to would rather have a little bit of the movement and be able to move and walk comfortably than to be off and really symptomatic with their Parkinson's disease. So even once you start getting dyskinesias, the medicine is still usually very helpful in most patients and still absolutely worth the trade-off if you believe all the patients that I've asked about this over the years. So, yep.
I just want to add that I'm actually, as I mentioned earlier, some of what you can see in my body is the writhing of dyskinesias. And what Dr. Brandenburg says about wanting the medication nevertheless is definitely true. It's much worse to not be on than it is to have these movements.
Yeah. The other thing about medication side effects in general is that sometimes I think we scare the bejesus out of patients by talking about these side effects, and not everybody will get every side effect. And some of the side effects we can actually fix with either other medications or by changing the dose or stopping a particular drug. So I think sometimes if we say this medication might possibly cause this, like say maybe it's going to cause some nausea in some patients. Patients get the idea that A, everybody gets the nausea, and B, we're just going to say, oh, sorry you have nausea, I guess, have a nice life with that nausea, and we don't. We do something about it. So that's the other thing to consider. Sometimes I think we emphasize the side effect so much that we really forget to talk about benefit. So. And I think there was an earlier question about is rasagiline or Azilect neuroprotective? And the answer to that question, first you have to think about what is on the label indication. So what the FDA has let them say that their drug may or will do. The label indication for Azilect is as a treatment drug to treat the symptoms of Parkinson's disease. The idea that it could be neuroprotective has been suggested by some of the studies, but the FDA has not yet reviewed all of that data and decided whether or not it will let them put that on the labeling. So I just heard that question came up earlier. So I'm going to turn it back over to the panel. Thank you.
Okay, I think we'll take one more question, and then we'll go to the food. No, wherever we go. We'll go. Going once? Going twice? Let's say thanks to our panel, and they will be here for several minutes.